and say welcome. This is 1 year on since we started. The first masterclass we did was on April the 27th last year. And at that time, there was nothing else on Zoom. In fact, I didn't know what Zoom was. And we were then running every 2 weeks. But now there's a lot of other things that you can go online and watch. So this is the 1 year, and this would normally be, we would have had this face-to-face. We had a whole year now of non-face-to-face meetings. Anyway, Chandler, as you all know, is a real expert in male and female reproduction. And this is a whole series of talks, and I've got one at the end to update everybody on hypertension. And before that, Alex is going to do his osteoblast. So, Chandler, over to you. If you'd like to start and explain to everybody what the right age of menopause is, I'll be grateful.
Thank you very much, Kareem, and it's really nice to see so many people joining the call, including some familiar faces and friends. Before I go on, the majority are correct in this case. So the average age in the UK of menopause is 51. Okay. Right. So I'm a consultant endocrinologist, and I'm very fortunate to work alongside gynecologists in the Department of Gynecology at St Mary's Hospital, and that's helped me to, I don't know about you, but when I sort of instinctively think about hormone replacement therapy, this is often what I would have thought, and I can identify that with speaking to some of the registrars that I meet, that it's often thought of as quite a tricky subject. And I think that's quite understandable, partly because we don't always treat it. Gynecologists and GPs prescribe the most HRT, more than endocrinologists, and yet we do need to know about this as well. Other questions? Well, there are lots of preparations. It's not like thyroxine or many other hormone therapies where there are a smaller number. There are probably more types of HRT than there are insulin. In fact, I'm sure there are. And also issues, when should you start HRT? So what are the indications? What are the risks of it? Serious risks like breast cancer and clots. And what happens when you start HRT but your patient doesn't like it? So these are things that often make people uneasy, and hopefully we're going to deal with pragmatically all of these issues to give ourselves a bit more confidence and clarity on the subject. Okay. So in sort of spirit of the masterclasses, rather than sort of giving a lecture with lots of theory, we're going to hang it around some cases. And I really appreciate your involvement in the multiple choice questions. I think it makes it more interesting. It's nice for me to see what you guys think as well. Okay, so we've got a 47-year-old woman whose period stopped 14 months ago. And she's got hot flushes 2 to 3 times a day, and they're mainly nocturnal. And she's finding it difficult to sleep. In fact, sometimes she wakes up with bed soaked because of perspiration. And she's really finding it difficult to concentrate in work, and her mood is certainly lowered, partly because of the sleep loss and the flushes. But she also really does feel quite depressed. Otherwise, she's in pretty good health, and her BMI is she's just slightly overweight. So in order to make a diagnosis of what you think is wrong, I'm going to ask you which of these you think need to be done. Right, okay, very interesting. So we've got 2 big camps. It's like election night, isn't it? So this is actually dealt with by NICE, but I'm going to reveal the answer in a second, but I'm going to actually now adapt the question. I'm going to adapt the question, and we're going to repoll the question. So now I've changed one line of this case. This 47-year-old woman has periods which haven't stopped, but they've become less regular every 2 to 3 months during the last 10 months. Everything else is the same. She's got hot flushes. So my question to you is, it's the same options. What do you want to do to make the diagnosis? Very interesting. So the vast majority, again, are going for measuring reproductive hormones, or some people think you can make the diagnosis up front. I agree with the people for both answers who think you can do nothing. And let me explain. Clearly, you can measure reproductive hormones. I think we know what we're likely to find, that the LH and FSH will be elevated in estradiol. In the first case, will be low. Here, because they're still having cycles, they may well have detectable estradiol. And the NICE guidelines are actually very helpful. They're very helpful guidelines here, and they provide some tremendously useful advice. And so this is quoted, virtually word for word. So if you have someone aged over 45, and this lady's 47, you do not need lab tests to diagnose perimenopause or menopause. So menopause is made by diagnosing basically secondary amenorrhea. So her periods are stopped for more than 12 months, and she's not on hormonal contraception. So, and this is done day in, day out in general practice, and we don't see these people. So generally speaking, and she has suggestive menopausal flushes as well. And if she did have just oligomenorrhea, but in combination with vasomotor symptoms, again, which she had, you can diagnose perimenopause, which is essentially a one-way street towards eventually having menopause. Either way, NICE recommends that to make the diagnosis, you are on safe grounds doing it using clinical acumen alone. And this is mainly because it's a numbers game, because in someone who is over 45, then the probability strongly suggests that what you are dealing with is menopause or perimenopause respectively. Clearly, if there's something unusual in the history, then you can deviate from that. Now, in someone who's less than 45, then other causes for amenorrhea can be looked for, and FSH is useful there. So clearly, if an FSH is greater than, say, 25, then that's highly informative. Greater than 25, then that's highly informative and suggestive of the same diagnosis. Okay, great. So again, so what I'm doing to this case is trying to sort of stress test it, and to as a way to sort of test what we think we would do. And this is really designed on previous experience of the types of questions that I face, and I know that you probably all face as well. So now we're going to go down the route of how we deal with breast cancer history. So apologies for making the case the same, but we're just trying to change one fact about it, and that's her mother had breast cancer. Okay, so let me just quickly go to the next case. Right, so it's the same case. So she's going through the perimenopause. She's got severe, vasomotor symptoms, but this time in the history, her mum got diagnosed a few years ago with breast cancer and had a mastectomy and chemotherapy. So, and you can pick more than one answer here. Which do you think is true? It's HRT is not advisable in this lady because of the contraindication of breast cancer. Number two, you can offer HRT after having a frank discussion about the risks and benefits. Third option, you can consider HRT if something else hasn't worked, such as an SSRI, clonidine, or gabapentin. And finally, HRT has a much higher risk than we thought of breast cancer. It's in fact threefold higher when you take HRT than if you do not. So which do you think is the correct diagnosis? Right, so we've got, so 74 people out of 87 think that it can be given after discussing risks and benefits. 14 have said that it should be second line. 16 have said that it increases breast cancer risk threefold, and a small number have said that it's not advisable. So I agree with the 76 here. Again, I agree with the majority. Let's just go through some evidence to explain and justify why I think so. So, there is often not a month that passes without a headline, it seems, about HRT doesn't it cause breast cancer? However, I think things have really shifted since this very large study performed from Oxford, coordinating in Oxford, was published in the Lancet in 2019. And what this did was it accumulated individual patient data and performed a meta-analysis. So they created an enormous database. It's a very well-known study. And they looked at women between these ages, sort of 50 to 59. And what they found was that in the women who didn't take HRT, so again, this is looking at meta-analysis of lots of other clinical trials together with different characteristics. But overall, they found that if you didn't take HRT and you were in your 50s, then your subsequent risk of breast cancer in the follow-up period was 6%. But if you took HRT, so estrogen plus a daily progesterone for 5 years, so if you took a daily progesterone, their headline was that you increased from 6% to 8% your breast cancer risk. And it was a bit lower if you had intermittent, so cyclical progesterone in your HRT, which many people take, so that's 7.5%. And if you were just taking estrogen only, so if you didn't have a womb, a uterus, then it was less marked. And this is a kind of a forest plot of the meta-analysis, and I've just highlighted for you. So this central line here shows if something's on this line, it means it has equivalent risk to not taking HRT. And you can see with estrogen-only preparations, it didn't matter what type of estrogen you were taking, the relative risk was about just under 1.5, say 1.3. And if you took estrogen plus any form of progesterone, then there was a higher risk. And if you took the progesterone daily versus intermittently, there was this differential risk. So it seemed that estrogen confers a risk of breast cancer. And if you add progesterone, there's an additional risk. And the more progesterone you take, the higher the risk. But overall, in context, you have this, if you look at the overall figures, then there's a 30% increase in breast cancer risk from 6 to 8% at worst, but at best, much, much lower. Okay. So unfortunately, when that article came out, this was what was actually on the front news. Pause it, do you get it? Menopause. HRT treatment for menopause increases risk of breast cancer by 1/3, experts warn. And the danger remained for more than a decade. So this is all very, very worrying, I think, if you're taking HRT. And I had a lot of patients asking me about the study, wanting to know more, and many of whom stopped HRT because of this. And I don't think that's, I think we need to tackle head-to-head this type of data. And actually, I tell people about this study, and I talk through the increase of 6% to about 8%. So I give the worst figure. And so if you say, if you don't take HRT and you're 50 years old, 6 out of 100 will get breast cancer, and you get a couple of extra cases, then people will react differently. Some people will clearly not find that acceptable, and some people will. But I think more balanced reporting would be helpful. And I think it's also important to, when you're counselling women about the risks and benefits of breast cancer, to put things in context. So, this was published pre the Oxford study. So the relative risk will depend on the type of HRT you're taking, but it's not vastly different to this. But if you look at alcohol, you have an excess risk. Being obese, excess risk, and high intake of saturated fat, excess risk, in addition, of course, to family history. So I think a nuanced approach to counselling these women, looking at their overall risk of breast cancer and counselling them on the evidence that clearly HRT does increase breast cancer, but not threefold, to a lower extent. HRT is advised as the first-line treatment for this woman. And that's because you could give something like an SSRI or clonidine or gabapentin to treat her menopausal flushes. but they're not very effective. It's not a very good treatment. So the first line treatment, and NICE does support this, is HRT still, provided you really talk about the risks and benefits and you have a shared plan. So clearly, does this bother her enough to lead to a slightly increased risk of breast cancer? And if it's mild, then clearly they could take something else, maybe take some herbal supplements, something like black cohosh perhaps. But if it's bad enough to need medication, then HRT, in my opinion, is the first line and best thing if they're willing to take it. Okay, so we're now going to kind of center on and talk about what's often a tricky area. And I've tried my best to try to tackle this in different ways, talking about the types of HRT to make it as clear as possible. So first of all, what types of HRT are out there? And I think, first of all, we could think about the route of administration. So you could take tablets, and we know because of first pass metabolism, tablets have a slightly higher risk of thrombosis, etc. There are transdermals, so such as patches or gels, and there are vaginal types of HRT which give localized benefit only, and they can be really useful for things like pain during intercourse or vaginal dryness. Okay, so those are the types. And what about the arrangement of taking HRT? Well, the thing that they all have in common is that you have continuous daily exposure to estrogen of some sort. Whereas with the pill, you often have an estrogen-free zone a week. Whereas here, every day you're taking estrogen. So for example, if you take cyclical or sequential hormone replacement therapy, and I endorse no brands at all, so I've done my best to try to spread the brands and not give just one. So things like Olestuet or Femiston could be given. And what each pack of 28 days contains is 2 types of tablets. And the first 14 days will just contain estrogen. And that will thicken up the womb. And then the final 14 days will be a different color. And that will contain the same estrogen plus a progestogen as well, which will then make the womb secretory. And once that progesterone stops, the pack ends, then you should get a withdrawal bleed. Of course, you don't need to take the progesterone every month. It could be given after 3 months. And generally speaking, for safety, to prevent endometrial hyperplasia, you want to be having about 4 bleeds a year. So you could have monthly bleeds, or we'll go into it a bit more detail later, you could have 3 monthly bleeds. The other thing is you could have a continuous combined pill or patch, such as Everel Conti patch, where you're always taking estrogen and you're always taking a progestogen. And what that means is that you will eventually get down regulation of the endometrial receptors, and you're not going to get bleeding at all. You'll have a thin endometrium and you'll always have estrogen and progesterone exposure. And this obviously suits people who don't want to have a bleed. Okay, all right. So trying to sort of straw poll your views on this, but also to see try to explore the different types of HRT. So we have a young woman who actually had a bone marrow transplant for thalassemia when she was a teenager. Unfortunately, this rendered her with premature ovarian insufficiency after needing a radiation, bone marrow transplant, etc. She's 21 years old. She's a personal trainer. She likes going to the gym, running, swimming. BMI is 22. She's on no medications. Very, very good physical fitness. So for her, and again, there's more than one, there isn't a single right answer here. I'm just interested to see, for us to discuss what might or might not be more suited to her. So in other words, what do you think? Would you like to give her a patch containing estrogen and norethindrone, such as Everel Conti? Would you like to give a tablet containing estradiol valerate and norethindrone, such as Olestuet? Would you like to give her a tablet of estradiol, valerate, and dihydrogesterone, such as Femiston 110 or 210? Would you like to give estrogen gel and micronized progesterone, so Utrogestan, or a bioidentical compounded estrogen containing estrogen, progesterone, and testosterone? So I've deliberately been quite specific because I think it's important for us to tackle the anxiety I think we have about preparations, and we're going to have some slides talking about the individual preparations.
Can you go back to the questions? We can see.
Sorry?
Can you go back to the question? The slide.
Of course.
For a second.
Yeah. So this is a young woman who's had premature ovarian insufficiency. She's 21 years old. She's clearly very fit and active, and she needs HRT. What would be your first line HRT? What would you like to give this woman? Let's have a look. Very good. So we got a really nice spread, haven't we? And very interesting results. So everyone has, every every option is fairly popular, and maybe the estrogen gel and micronized progesterone is less popular. So let's go back and look through. So considering everyone's votes. So that more than one is entirely possible and plausible. The one thing I would caution people against, which quite a few people voted for, was E. So there is a relatively new phenomenon which is called compounding pharmacies. And that's where a pharmacy will take individual ingredients of containing estrogen, progesterone, and testosterone, etc., and compound them to create bespoke tablets. And this is very much becoming popular on the internet, and NICE specifies very much that there is insufficient evidence to kind of support this, because by definition there's a lack of standardization, and therefore a lack of evidence underpinning whatever you're taking. And we would certainly sort of caution against this. Testosterone is something to be taken only if women who are menopausal have low libido on optimal HRT. So it's certainly not something that we would advocate taking proactively as routine in women who are menopausal. So I would certainly caution against E. Now, as for the other things, we got A, B, C, and D are reasonable options. They all are forms of HRT. And I would really speak to her and talk through the options. Does she want a patch or a pill or a gel? And does she want bleeds, or does she not want bleeds? In general, and as I said, you need to ask and confirm this. Many women who are younger in classically sort of reproductive years, so below, young women, will want to have something that gives them regular withdrawal bleeds, and that's because of the perception, correctly, or it's not correct, but technically, but fundamentally, having withdrawal bleed makes them feel that it's a more natural physiological state, and they identify with that more. That's not to say that they will all choose that, but something like a less duet, maybe more popular, or Femiston 1 or 210 will give them withdrawal bleeds. And also, if it fell out of their bag or something, then most people would mistake it for the pill. So again, it would be a natural thing for someone to be carrying around, and much less innocuous than something else. Often, younger women may prefer less the patch, particularly, or gels, particularly if they're active. And I was careful to put in the history things that would either put her in contact with water or perspiration. So things like the gel or the patch may be seen as faffy, and also potentially embarrassing if they're wearing things which are sleeveless. But that's not to say that they won't be liked. And also Everel Conti, so we'll go over this later, but this is a continuous form of HRT where every patch always contains estrogen and the type of progesterone, nortestosterone, and therefore she's not going to get any bleeds. So again, it's not cyclical. So In general, I would say B and C are going to be the most popular, but any of A, B, C, or D are reasonable. And obviously, we're going to leave some time to really talk through questions that you may have about this. I'm sure there will be. Okay, so types of progesterone in HRT, just to give you an overview, we have things that are, so there are several. And it's best to classify them in terms of anti-androgenic ones, so things like dydrogesterone, drospirenone, ones that are fairly neutral, so micronized progesterone, so that's just progesterone, or norgestrel or medroxyprogesterone, or things that are androgenic. And these are generally the only things found in patches, so things like northisterone or levonorgestrel. And these can often be quite good, the ones with androgenic effects in older women who may have low libido symptoms. So I said you shouldn't really give testosterone routinely, but we often give something with androgenic actions in older women because it can maybe not strictly evidence-based, but give a little bit of an androgenic action, which could be good for well-being and libido. Okay, and I think the crucial thing is, it's the progesterone that causes problems with tolerance. Okay, the estrogen is estrogen. Okay, it could cause a bit of breast tenderness, but by and large, it's much better tolerated than progesterones, which can cause sort of depression, bloating, and water retention. So this is by far the the cause of intolerance to HRT, and women will, in my experience, tolerate and like a particular one, whereas the next woman may like a different one. So there is a bit of individualization about tolerability to progesterones. And this is from NICE. So drospirenone, this is an aldosterone antagonist. So this can be quite good for women who may complain of fluid retention. So things like micronized progesterone, so in other words, eutrogestan or dydrogesterone, would be preferable in people with hypertriglyceridemia because they don't affect lipid profile. And the Mirena coil is useful where you just have women who will not tolerate and get problems with mood disturbance, etc., with the progesterone, or are having really big problems taking cyclical HRT with heavy beads. So you can just give unopposed sort of estradiol valerate every day and a Mirena as well, if none of the progesterones are tolerated. Okay, so in terms of HRT, which is best given to younger women, well, there's ready-made ones that give monthly bleeds, and these tend to be the most popular, and any of these will do. However, there's also the tailor-made approach, which is where you could just give estradiol valerate, say 2 milligrams, with a progesterone such as eutrogestan or Provera, medroxyprogesterone, and you could give that every month or every 3 months, or you could give a Mirena. So I have some teachers who really like to just give themselves estradiol valerates, and I give them packs of progesterone to take during school holidays so that they only have a bleed during the holidays, and they like that flexibility. So there are different ways of doing it. Okay, moving on. Okay.
You want to mention at the end?
Pardon?
There's a couple of questions in the chat. In this young lady with POI,
Yes.
why HRT not the OCP?
Very good question. Very, very good question. I'm sorry and I'm not going to cover that, but I'll answer it now. So the OCP contains an estrogen active anabolic steroid, which is called estradiol, which is called ethinyl estradiol, and it has far inferior action, so it's suppressive rather than being physiological, and it also inhibits IGF-1 secretion from the liver, so the effects on bone are far less beneficial and can, some studies say, detrimental compared to HRT. So in someone who is menopausal, particularly POI, who needs bone mineralization, giving the pill will offer little benefit. That's why it's really important to give physiological estradiol valerate or fumarate replacement in the form of HRT. Is that all right, Kareem?
Yeah, that's fine. She's worried about pregnancy, but that's very unlikely, I think, in this patient.
Yeah. So I guess we would assume that given her history, there'd be in fact, we will talk about pregnancy a bit later on. Okay, so next patient, this we have someone who's 67 years old. I know what you're saying. We generally don't give HRT to women who are that old. However, she has really troublesome flushes, more than 10 flushes daily when she tries to stop HRT, and really low mood. It's detrimental to her quality of life, and she's desperate to have something. So I'd like you to tell me what you'd like to do. Would you like to trial St. John's wort? So something from Holland and Barrett or a similar health food shop like black cohosh before. So ask her to take that and bring her back after 3 months. And if that doesn't work, then consider HRT. Or would you like to go straight in and give her a patch? Would you like to give her a tablet, so a combined pill? Or would you try something alternative, maybe gabapentin or an SSRI? Or give a gel with the Mirena coil to stop endometrial hyperplasia. So we got several options. More than one, I think, is correct. Have a go and tell me which one you think is, which ones you think are best or acceptable. So let me put the history back. So this is someone who, you know, we wouldn't routinely give HRT to someone of this age. However, she has really bad flushing and she's got low mood and she's got no cardiac history of diabetes. Let's say also she has no history of breast cancer as well. Okay, so we've got a good spread. So everything apart from the tablet has been favored. Quite a lot of people going for a trial of gabapentin and SSRI. 15 want to give a trial of alternative therapies. HRT patch is popular. So let's go back to the case. Really great answers. So I would say that, first of all, in this woman, she's got clear evidence of severe vasomotor symptoms which are interfering with her quality of life. And therefore, the only efficacious treatment that we have, you know, highly efficacious treatment is HRT. Things like St. John's wort or black cohosh, look, they may help. They may help. They're unlikely to, in someone who's flushing 10 times a day, help. I think if someone had mild or moderate, you know, mild flushing, much less severely, then you might ask them to do that. But I think the fact that they've been referred to you and they have such severe symptoms and lowering of mood would fit, and I think is justification to give HRT. Now, because of her age, cardiovascular safety is really important. So I would caution against, we would like to avoid giving something that's tablets. So if we're going to give something, we want to give something through the skin. So a gel or a patch. I think having a Mirena, if she will take it, is a great option, because then she could just have gel, or you can get patches like, you know, just Everel on itself. That would be a great option. Or you could have HRT patch, which has two versions. So one is Everel itself, so just estrogen, and then you swap it for the latter 2 weeks with estrogen and a progestogen, and then when you swap back to the estrogen alone, you get a bleed. So you alternate between estrogen and progesterone, estrogen and progesterone. So and gabapentin and SSRIs, they just don't work very well. So by all means,
from somebody, how long can she carry on with this?
Very good question. So clearly, we would every year at least have a conversation about the risks and benefits, and I always try to discourage its use, particularly in this age group, unless they really need it. And we have to be upfront about the increase in breast cancer risks, and we've gone through the data. And the answer is, I've got 2 people who are in their 70s who have severe intractable flushes, and one of them has developed angina, and we've stopped it, and she still has flushes, but we stopped it because of the risk versus benefits. So the answer is, as as long as needed, but no longer than needed. And it should be an exception. So really, what are the indications for giving HRT in someone of this age? Intractable severe vasomotor flushes is a very, very good reason. The other, when it gets to pure sort of depressive symptoms, then I think, a conversation and thinking about antidepressants may well be a better option in terms of safety. But here, where you've got vasomotor symptoms, it's difficult to think of anything else that's going to work. Okay. So HRT, which can be, first of all, I showed you HRT that could be given ideally to women who are young, below 50. But if you're above 50 or below 50, you could have some of these. So you could have a ready-made pack, pre-packed, which gives you bleed. So something like a patch with norethisterone, so that's Everel, or a patch with levonorgestrel, so that's Fem7. And again, they each come with sequential or continuous varieties, which will give you bleeds or no bleeds. Or you could have the gel, such as Sandrina, but you've got to have something if you've got a uterus to prevent you getting endometrial hyperplasia, such as a Mirena coil, or cyclical progesterone, or cyclical medroxyprogesterone. Or you could have a ready-made thing with, so I've just gone through all of that as well. So you can either have them with bleeds, such as Sequi, or you could have no bleeds, the Conti versions. Good. Right. Moving on. So I guess to round things off for this section, intolerance to first-line HRT is common, and you can simply swap to an alternative. So what happens if, with all the best will in the world, you start them on something and they say that it's giving me bloating, or it's my mood's lower, I don't know, I don't like it, then that's fine. And I often warn them that it's just like, trying something on, it may not fit you. You may have an intolerance to the symptoms. And if it is, it's okay. And I often give the GP instructions in my clinic letter about a second line agent so that they have license to change it between the clinic appointments. And as long as it fits with their needs, which is, are they above or below 50? So thinking about transdermal, or can they take pills? Do they want bleeds? Do they want tablets, or do they want a transdermal? Do they want androgenic effects, or are they young, maybe have a history of acne and they want anti-androgenic effects? So the good thing is, in the formulary, we have more than one option for nearly every single thing. So I often proactively will give alternatives in my instructions. Okay, right, Kareem.
Yeah.
So I'm anticipating that we may well have a lot of questions. I wonder whether now maybe, have we got a lot of questions to answer? I don't want people to be shortchanged for.
Well, I'll tell you what. Let's go through some questions now, because they're relevant to what you just said. So first of all, what is the estrogen gel dose when using younger women? Must contain 50 micrograms as a dose. Is it meant to be the same as patches?
Right. Okay. So I must confess, I normally use the patches, so I very rarely use the estrogen gel dose. And we will, with the gel, presumably use the minimum. I would start with a low amount that is sufficient to get rid of, their symptoms, their vasomotor symptoms. So, for example, if you use a tablet, they will come as 1 milligram or 2 milligrams. And if someone's very, petite or have a low body weight, then I'll start with the 1. But otherwise, if they're young or they're taller, etc., or have a higher weight, I'll start with the 2. So it is empirical, but as a mantra, particularly the older you get, and thinking about cardiovascular risk, it's the minimum dose possible.
There's a couple of questions about micronized progesterone.
Yes.
First of all, what is it? Somebody wants to know. And then compared to Provera, what are the risks?
Yes. Okay. So micronized progesterone is basically progesterone itself. So I was talking about, and maybe I should sort of flick it up on the screen, the different types of progesterone that are out there. Sorry, forgive me. here we go. So these are all analogues. These are all steroids which have progestogenic activity, but one of them is progesterone itself. And utrogestan is the licensed form of progesterone. So it is progesterone, the natural progesterone. Now, if you look sort of in terms of evidence, there's a push to giving people natural progesterone because it's meant to be safer. However, that wasn't really borne out in the Oxford meta-analysis. And I think that may reflect that there's less outcome data. So the absence of showing bad effects does not mean it's better. And I just see it as another form of progestogen that you could give to give withdrawal bleeds. And I think there's a movement for a lot of people to have it, but I often use medroxyprogesterone as well if I'm or any of these other things. So generally speaking, give the progestogen that you're comfortable with, that your patients like. But utrogestan is commonly given if you're giving estradiol valerates plus something. And it'd be interesting to see whether outcome data bears out this difference of safety.
There's a question about switching people from the OCP to HRT, I guess at that age. You just switch them straight over?
Yeah, I've done it many times. So I have lots of people who transition over from pediatric care, and absolutely. So by and large, it's used often the OCP, and we'll simply just once that PAX finishes, just start them on. In a young woman, as I said, unless they are sort of their weight's below 50 kilograms, then I'll generally give them a tablet containing 2 milligrams of estrogen daily. So something like, again, not endorsing brands such as Femiston or LS Duet or equivalents can be quite good. So that they have a good, generous dose of estradiol replacement.
Okay, there's a question about functional amenorrhea. Do you use estrogen in those patients?
Yeah. So if we're talking about functional hypothalamic amenorrhea, so to do with exercise and low body weights, then absolutely. And there's, I was talking about the OCP not really giving good mineralization. It's particularly the case with this group where a lot of evidence has been done by pediatricians. And because you suppress IGF-1, you get this real double whammy, and actually giving the pill can, in some studies, lower bone mineral density. So it's really important if you're going to give, if you can persuade these women to take HRT, to not give the pill unless they really want contraception when it's entirely appropriate. So the HRT as opposed to the pill is definitely recommended.
Do you think women with persistent hot flashes have an increased risk of cardiovascular disease or coronary artery disease? I think
that's a really, really good question. I don't know if per se they do. We know that, and colleagues of mine working in Imperial have been doing Aliabara, Morgadillo, Alex Komnenos, who's speaking later on, done a lot of work on this. So we know that there's something called neurokinin B in the hypothalamus, which regulates the thermoregulation and vasomotor responses in the body. And by the lack of estrogen feedback will increase neurokinin B by lack of feedback and activate these neurons. So simplistically, HRT will switch that off again. As to whether it's particularly associated with cardiovascular, I don't know.
Yeah. Okay. And then there's a question about why I don't know if we do we give women who have got PCO the OCP instead of HRT?
Very good question, and that's entirely right. So with PCOS, unlike what I've been talking about, so the menopause, I've been talking about a hypogonadal state, which is the menopause, and also another one was mentioned, so that's hypothalamic amenorrhea. So we simply want to give physiological replacement. Whereas in PCOS, they are normogonadal. They have entirely normal levels of estradiol. And actually what we want to try to do is suppress levels of androgens. And what we do is give supraphysiological hormones, so steroids. So we give the OCP to basically suppress that. So it's an entirely different indication and entirely different therapy. So HRT would not work.
Okay, maybe last question. Is there an estimate of breast cancer risk with HRT use beyond the age of 60? And just I should also add, in that thing from the Sun, when it says there's a third increased risk, The problem is that patients read, a third of patients get it. And that's the problem. The word third was in bold. And so a third increases from 6 to 8%, whereas the word third misleads people quite a lot.
Exactly. And, I think that this was a problem with the press release. And I think that's why, that's the reason I put that specific data up there, because I think we have a job to not, push HRT, but if people need it, then counsel them of the risks and benefits. And the same two different people will one of them will say, oh no, I really don't want to get breast cancer. Okay, tell me about that, doc. Let me try something else. I'm going to go to Holland and Barrett. And the next person will say, that's fine, I'm not bothered. It doesn't seem like a big risk. And it's our job to be dispassionate and proportionate about counselling. So she underwent menarche at the age of 13. Periods were clockwork. And then 15 months ago, her periods became less regular and frequent. And now she hasn't had a period for the last 6 months. So these were her blood tests. She was seen a couple of years ago in March, in June, and December. Okay, so LH, FSH, and estradiol. So pretty clear that she has premature, she's in her 20s, so she has premature ovarian insufficiency. So I'm not asking you that. I'm asking you what investigations you'd like to do for this woman with POI. So do you think she should have, again, more than one answer is correct. So do you want to do a karyotype, Fragile X mutation screen, anti-Müllerian hormone, adrenal antibodies, thyroid antibodies? What investigations would you do? Let's stop there. Aha, everything's popular, right? So everyone, so so all of the tests apart from AMH are recommended. And if you don't believe me, I'll go on to the next slide. So let me go back. So I would say that AMH is not required. AMH is is made by enlarging, enlarging follicles, and you just, we know the diagnosis. We know that she has an absence of ovarian activity. So that's not needed. What we need to do is, what's recommended is an investigation screen looking for underlying causes. So she has premature ovarian insufficiency. This is diagnosed below the age of 40 by definition. An amenorrhea more than 4 months is required, and an FSH greater than 25 on 2 occasions is required. And it's quite a useful rule of thumb. So it affects roughly 10% of women less than 40, 1% less than 30, and 0.1% less than 20. And this is from my good colleague, Lisa Webber, who works with me at St Mary's Hospital, who's first author of the HRT Guidelines. And this is the recommended panel. And I think, different hospitals will take different things, and we may not do everything. But this is certainly what the recommendations are, covering for autoimmune disease, Fragile X testing, and which may have screening implications for relatives, and certainly a karyotype, obviously, for Turner syndrome. And the last thing I want to finish with is what happens when, basically that she wants to conceive. What's her chance of conceiving naturally, and what are our treatment options? Well, in terms of chance of future pregnancy, there was a really brilliant study done in France about 10 years ago, showing that there's a 5% chance, a 4 or 5% chance of spontaneous pregnancy in women with POI. And this almost always happens in the first few years after diagnosis. And that's because you can get spontaneous reversion and recovery of ovarian activity for a few months. So if they're having regular unprotected sex in the first few years after diagnosis, there's a 4% chance of spontaneous pregnancy. Now, unsurprisingly, her AMH is less than 2 picomoles per litre. So what are her treatment options? Well, IVF is highly inadvisable, because if you give her FSH, her FSH is already high, it's not going to work. And I don't know of any clinics in the UK, certainly, who would agree to take on a patient and put her under a superovulation protocol with the condition that she has. And egg donation is increasingly popular, and the NHS has increasing amounts of provision for NHS donor IVF cycles. So you're still under the same eligibility criteria. But if you are menopausal, then you can have, rather than IVF, donor egg IVF instead. Okay, fine. So I'm gonna save a lengthy talk about AMH and when it can be used for another day, because I'm aware we're running short on time. But are there any other questions, Kareem, that have come through on the chat?
Yeah, there are some quite raw ones that may not be that relevant. I try to answer one on the thing. In POI, is AMH helpful? Because you've just said that.
Yeah, I think a lot of people think this, and I think because it's a test that's out there, we feel we should do it. I think in POI, the cardinal feature is obviously the history and the FSH greater than 25 on 2 occasions. I have seen cases where it will go 25 and you may have an ovariitis and then it goes down again. But when it goes above 25, then there's a high risk that it's gonna happen again. So I would say an AMH is not required.
There's a very broad question about how you manage post-pill amenorrhea.
Yeah. So I mean, in brief, post-pill amenorrhea is where you get a delay in period starting when you stop the pill. It's very uncommon for it to last more than 6 months. So it's within 6 months, well, it can't be post-pill amenorrhea, that you just have to wait. And after 12 months, it's incompatible with the diagnosis. So if someone has stopped the pill and it's been more than a year, then forget the pill. You've got to look, they have secondary amenorrhea, and you've got to investigate them for things such as polycystic ovarian syndrome, prolactinoma, thyroid, hypothalamic amenorrhea.
Thank you. In hypog, due to exercise, if she wants to get pregnant, would you put her on HRT first?
Very good question. So in functional hypothalamic amenorrhea, if they want to get pregnant, do you put them on HRT? So the answer is that if the most important thing they want is a baby, and they want a baby, let's say in the next year or two, then the focus of our discussions would really be about trying to address lifestyle factors. So to try to have a graded increase in body weight, go for lower impact exercises. Sometimes referral for CBT can be useful. And some of the delegates on this call are real experts in this field. Now, generally speaking, if they wanted, now HRT won't disguise the restart of periods, but it can make it a bit more complicated. So I think if it's for the sake of a year's waiting and everything, I won't start HRT. But if it's longer and they just have a general interest in seeing whether they can restart their periods, but they are single and they don't want to have a baby right now, then HRT is ideal.
Okay, and last question before Alex starts. So if someone's on the OCP and is having symptoms of the menopause, how significant are lab tests?
Okay, so if someone is on, lab tests are really unhelpful, because what they will do is suppress your gonadotropins, so preclude your ability to look for an elevated FSH. So I would stop the OCP and bring them back after, say, a week or two and recheck.
Okay, now I wonder whether, Alex, do you want to share your screen? And also, Chandler, do you want us to turn off, have you got to your last question? And then
Yes. So shall I turn off the Mentimeter thing?
I think that would be good, and then either I or Alex can take it on. Let me just check that he's.
Yep, so I closed it.
Part 10. So yes, just to say, so a year on, exactly a year ago, we started these with Alexa's first osteoblast part 1, and we've got 10 parts down the line in a year. So welcome, Alex. They're very popular sessions, and off you go. Thank you.
Thanks, Kareem, and thanks for the inspiration in setting these sessions up. And I didn't think I'd be on number 10 a year later. Anyway, so I presume you can all hear me. Kareem, can you hear me?
Yeah, perfect.
Okay, good. So let me just maximize my screen. So it's been a real pleasure being involved in this series, and I've interacted with a lot of endocrinologists around the world. as a consequence of this have asked me various questions. So I really appreciate this opportunity and interacting with everyone. So number 10 today, you can see in red are the questions that we've covered so far. Okay, from the very beginning. I think actually the very first one we did was on renal bone disease. And so today we're going to talk about denosumab. And is it okay to stop denosumab? And how should you stop denosumab if you really need to? So a little bit about denosumab. So we've had it for about 10 years. It was approved by the EMA, I think in May 2020. So we've got 10-year data now on it. And as you know, it's a 6-monthly subcutaneous injection. It can reduce your risk of future vertebral fractures by about 68%. So that's from the latest network meta-analysis published in JCL a couple of years ago, and reduces your hip fracture risk by about 39%. So these are real whopping reductions in fracture risk, 68% for future vertebral fractures and 39% for hip fractures. And there in brackets, you can see the equivalent reductions for other medications. So teriparatide is slightly superior, zoledronate slightly inferior, and then you head downwards to alendronate 43%, raloxifene 41%, and HRT that Chan has just been talking to us so excellently about is down to 35%. Okay, and so it's a very potent medication. How much does it cost? Well, you need 2 injections a year, and each injection is going to cost £183 for the actual denosumab, and then you've obviously got the costs of administration. There are some programs available around the country for patients to self-administer, and we did have some patients who did this during the COVID pandemic, and we're trying to seize this opportunity. And there are some GPs who are also willing to prescribe and administer denosumab in their practices as part of a shared care pathway. But it's expensive, £183, which, you know, if you think zoledronate is perhaps 10 to £20 for 5 milligrams currently, if you use 2 smaller vials. So how does denosumab work? So as you can see here, hopefully you can see my mouse. This is the osteoblast, B for blast, builds. Okay, so it's building bone. And here you've got the osteoclast, which is chewing up the bone like Pac-Man. Okay, now the osteoblast secretes these little purple, obviously they're not purple, but in real life, but they're these little purple balls, which are the rank ligand, okay, receptor activator of nuclear factor kappa ligand. And this rank ligand goes and sticks onto rank receptors on the osteoclast precursors and promotes the differentiation, the activity, and the survival of osteoclasts. So you get more chewing up of the bone. Okay. However, denosumab comes along into your bloodstream. It's got a half-life of, I think, about 29 to 30 days, and it will bind to these rank ligands and prevent them from binding to these osteoclast precursors. This is a very similar role to what our endogenous osteoprotein does, which is these green things. But it supplements this. You've got these denosumabs that come in, bind to the rank ligand, so it's a human, a fully humanized monoclonal antibody, binds to this rank ligand and prevents this differentiation and activity and survival of these osteoclasts. You get less bone being eaten up. Okay. So if we go on to the interactive case, it hopefully is on Mentimeter, and I think Chandler is kindly activating the Mentimeter. But if we just stay on this slide for a second.
So actually, Alex, I think, I'll do that. I'll do that.
Okay.
Yeah.
So it's a 73-year-old woman. She attends your clinic for review. She's been on 6 monthly denosumab for 2 years. So she's had 4 injections. She's also on calcium vitamin D supplementation. She has no history of fragility fractures. Her DEXA shows that things are improving. So 6% and 3% in the spine and hips respectively. And she's in the osteopenic range at the moment. Now she comes to the endocrine clinic and she's adamant that she wants to stop all these injections to minimize appointments. She doesn't want to come up and down to the hospital, especially during the COVID pandemic. So what would you recommend? So there's option A and B, basically involves stopping the denosumab and giving a treatment holiday, and then reassess everything in a year or 3 years. Option C is to switch to once a year denosumab injections instead of every 6 months. Option D is to switch to Zelegenate. So you've given her last denosumab, and then 12 months later, you give her IV Zelegenate. And then option E is to switch to weekly oral Alendronate, starting at the 6-month post-denosumab, so when she would have had her next dose of denosumab. Okay, great. So just to go through those options, so there's quite a wide choice. I would go with the purple people who would switch to oral Alendronate, and I'll tell you why now. If Kareem, so treatment holiday doesn't exist. This concept, it's a bisphosphonate holiday, and it's only for bisphosphonates. Okay, so treatment holiday doesn't exist for denosumab. It's not a good idea. It was a suggested idea maybe 5, 6, 7 years ago, but now we know how reversible denosumab is. This term has been erased, essentially. Okay, so no treatment holidays. So switch to annual denosumab injections also would not be ideal because it's so reversible. You will lose the benefits very rapidly, and you will also enter the risk of multiple vertebral fractures, which can occur from month 7 post-denosumab dose. So this would not be advised. Switching to annual intravenous Zelegenate would be an option, but 12 months is a bit late because you will, for reasons I will go through, and my preference would be to switch to oral Alendronate starting at 6 months post-denosumab. So the basic concept with denosumab is that it's reversible. So you suppress your bone turnover markers, but they're always starting to come up towards month 6, and then you give them at month 6, you push them down again. Unlike bisphosphonates, where it takes much, much longer for those bone turnover markers to start to rise. Then what you want to do is you want to stop, as they rise, you want to stop them overshooting, which is what tends to happen with delays or cessation of denosumab. The bone turnover markers overshoot, so you have hyperactive bone remodeling, and this is thought to contribute to the excess risk of vertebral fractures, especially multiple vertebral fractures. So you want to get in there as they're starting to rise. Therefore, option D would be too late because at 12 months they've already risen, and I will show you that they're already above the postmenopausal range. So it's too late, and you can have had vertebral fractures even at month 7, month 8 post denosumab. Now, don't forget these bisphosphonates. The way they work is they attach to remodeling bone. So if you give it too early, then it will just wash through and won't stick to your skeleton. And so therefore you need to time it right. For me, I often give oral Alendronate because you're getting a dose every week. So as bits of bone start to wake up, as they wake up from their denosumab slumber, then they get given a small dose of Alendronate, and that shuts down the bone. Another option is obviously you can give Zelegenate, but the bone needs to be as active as possible during the time you give the Zelegenate. Otherwise, you probably need to then give another Zelegenate, which I'll show you shortly. Okay, so is stopping denosumab okay? So here are some data. So this is on the y-axis, bone mineral density % change from baseline. And this is when given denosumab in the top lines versus placebo. And this is for 2 years. Okay, so this is lumbar spine, middle is total hip, and then the other one is the radius. Okay, so you can see for 2 years given denosumab, you're getting around 6% increase in bone mineral density in the spine, around 3.5 in the hip, and even in the radius, you're getting just over 1% improvement. Compared to placebo, which actually is tending to drop down as expected in a postmenopausal woman. Okay, so denosumab, great gains when you give it every 6 months for 2 years in all 3 sites. And this is reflected in the bone turnover marker. So this is percent change, so 0 is no change, and dropping down means it has been suppressed. So you've got over 80% suppression in CTX, which is the main resorption marker of osteoclast activity. You also get a decrease in P1NP, which is a marker of anabolic activity, the osteoblast activity, but that's because the osteoblast and the osteoclast are coupled, so they communicate with each other, so you tend to see similar direction. But overall, the net effect is that you will stop bone resorption and you may gain a little bit, and that's what's reflected here. Okay, so you've got great, and this is prolonged. This suppression is throughout the 2 years of treatment. Okay, so now we're going to stop the denosumab. Okay, you've had every 6 months, every 6 month domino. Now you put your hand and you're saying you're going to stop. So what happens here? So this is the red line. What's going to happen after this red line? So no more denosumab. And I put here in the yellow box is this dreadful situation where you will lose all the benefits you've gained over those first 2 years within 12 months in the spine, within 12 months in the hip, and within just over 12 months, 12 to 18 months in the radius. Okay, so if you don't give any further denosumab, you will lose all the benefits in 12 to 18 months. You're back to square one. Okay, and you can see even if you delay it by a prolonged amount, if you delay it by 3 months or so, you're losing substantial gains. Okay, you've got this big steep drop off following a delay. Okay, and this is just because the denosumab has washed out. Okay, it's no longer inhibiting the osteoclasts. In fact, what actually happens is all the osteoclast progenitors basically form an orderly queue because they're all paused in their precursor stage by the rank ligand inhibitor, by denosumab. Then suddenly the denosumab goes, and this big queue of precursors suddenly goes through the gates, and you get this flood of osteoclastic activity leading to this rapid loss of bone. And that's a mechanism that has been recently identified. Now, if you look at the bone turnover markers, you see this thing that I'm so worried about, this rebound increase in bone turnover markers. Okay, so the placebo, this is what would happen if we gave nothing. This goes along here, the triangle ones. But if you give denosumab, okay, you've got great reduction here, but then if you stop the denosumab without giving anything, it overshoots, okay, beyond the postmenopausal range. And this heightened state of bone remodeling is what brings this very worrying increased risk of fracture straight after denosumab cessation. Okay?
So quick question, how long can you continue the denosumab is the question.
So we've got good data now for 10 years that you can get continued benefits. So it's not like bisphosphonates where you'll see the benefits really in the first few years and then it will plateau and you just keep it there. With denosumab, you see continuous gains, at least up to 10 years is the longest data we have at the moment. And it's been around for about 11 years. So hopefully next few years we'll have even more data. But most would continue denosumab beyond 10 years. We can go into the ins and outs of when you would stop it later, perhaps. Well, I'll tell you now. Basically, what I do is use a sort of treat to target system, whereby once they get down to a T-score of -1.5, there's probably no real benefit in continuing on the denosumab, at which point you then want to lock in the benefits through various maneuvers, which I will go through now. So that would be the best way to approach this. So you take them down to a T-score of -2. The data is -2, but I go down to -1.5 because they will get this sort of, you'll see that none of the ways to stop denosumab works perfectly. So you risk it floating back up to -2.
There's another question. Can I ask another question about what if the patients put on denosumab because bisphosphonates were contraindicated?
Well, then, yeah, very good question. And the answer is then you continue the denosumab. You know, I've got one patient who's on it for about, I think, 12, 13 years before the European license. And so you will just continue. There are some other, you could use raloxifene to take them off it, but they may be too old to start putting them on a selective estrogen receptor modulator, in which case we await further medications and see what we can do. You may try shorter acting bisphosphonates, small trial, depends. It depends.
What agent would you use if a patient gets fractures on denosumab?
Okay, so that's a more general question. It depends if this is truly treatment failure. So I think maybe in Osteoblast 8 or 9 we went through what exactly constitutes treatment failure. Because don't forget, these drugs reduce your risk of fracture, but you can still fracture. Okay, reducing your risk with denosumab by about 68 to 70%. Okay, but there's still a 30% chance of fracturing, essentially. Well, 30% maintained chance of fracturing. So you need to firstly identify that this truly is treatment failure. So you need to also look at things like your DEXA. If the DEXA, the bone density, is dropping down, look at how well you're suppressing the bone turnover markers. And then what agent would you use? Well, to be honest, I don't think I can even remember seeing a patient where it hasn't worked, denosumab. I'd probably continue them on denosumab. You may add in teriparatide in some patients. I wouldn't switch straight to teriparatide because that's a bad sequence to do. Teriparatide does not work very well straight after denosumab unless it's added on to the denosumab, which is then continued. And there's also romosozumab, which is just coming out now and going through NICE, which is also an anabolic agent like teriparatide. Okay, so
it's quite hard to stop them, isn't it? But there's a question: why did this patient start? It's not this patient. Why would one start just for osteopenia with denosumab?
No, so this patient may not have been osteopenic. This is a made-up patient. So this patient may not have been osteopenic to start with, and so they were osteoporotic about 2 years. They're now osteopenic. But the second thing to stress here is that just because someone's osteopenic doesn't mean you don't treat them. And you may treat them with quite strong anti-osteoporotic medications. It's all about fracture risk, which you can calculate from fractures, because they may be osteopenic but on steroids, plus had 4 vertebral fractures previously. Remember, don't be captivated fully by the DEXA scan. Think of the whole picture. It's best to always calculate the fracts, which will take into account other risks, because don't forget, most fractures occur in the osteopenic population because they are the ones who make up the greatest number of people. Okay. So this is more evidence for why we need to be careful when stopping denosumab. So essentially, these are graphs here of patients. So this is a placebo. So the gray is off treatment and the white is on treatment. Okay. So this is your fracture rate, vertebral fracture rate, when you're on placebo, and then when you stop placebo. Okay, so unsurprisingly, there's a real difference. When you're on denosumab, obviously your fracture rate is lower. When you stop the denosumab, it goes up again. Okay, and the same here. This is for patients with prevalent vertebral fractures, and that's without prevalent vertebral fractures. Okay. Here, the problem is, as you can see here, this is the risk of having multiple vertebral fractures, okay? These two ones on the right, these two graphs on the right. And the worry here is that your risk after stopping placebo of multiple vertebral fractures is this. But when you stop denosumab, it's this. And this is higher than even stopping placebo. So there's this higher risk of multiple vertebral fractures on stopping denosumab than on stopping placebo. The error bars are quite wide, but if you look at it this way, basically look at this line here, of those who developed multiple vertebral fractures, a greater proportion had stopped denosumab compared to placebo. Okay, so there's this worry that this increased bone turnover, this highly active remodeling that occurs on stopping denosumab, predisposes patients to multiple vertebral fractures. And there's multiple reports of these multiple fractures in the literature. So the message is that when you stop denosumab, you're going to lose the gains within 12 to 18 months at all three sites. So your spine, in your hips, and in your wrist within 12 to 18 months. Very, very rapid, okay? Even a few months delay, you start losing a significant amount. And this is one issue we had during COVID of how to get their patients their denosumab during the COVID pandemic last year. And you've got this high risk of multiple vertebral fractures that starts from around month 7 to 8 after their last denosumab. That's when those bone turnover markers are now over the normal postmenopausal range. So if you're going to stop denosumab, think about an alternative agent, okay? And remember, this is not an issue with bisphosphonates because they have long-lasting protection on cessation because they don't allow this rebound effect because they sit in the bone for many, many years, okay? So this is the denosumab cliff. So those of you who come to clinic with me, you know I talk about the denosumab cliff, and here's a cliff I found in Iceland that nicely demonstrates this. This is increasing bone mineral density. So you give denosumab, your bone mineral density is going up and up and up, and then you stop the denosumab, and your bone mineral density suddenly shoots down. Okay, so this is the denosumab cliff. Okay. So what is the best way to stop denosumab? Well, there's many studies, and I've just put a few of them down here. Sorry, someone's knocking on the door. Hi, sorry about that. Okay, so one of the first one was the Fremantle study that basically transitioned patients from denosumab to alendronate at the 6-month point, so the point when they would have got their next denosumab injection, and there was fairly good stability here in their bone mineral density in the spine, the hips, and the femoral neck. Okay, but other maneuvers have also been tried, especially with zeledronate, and you can see a lot of minus numbers here. Okay, minus 9% when they gave zeledronate at 6 months, minus 5% here. Then more recently, these studies, minus 3%, minus 2%, minus 1.5% over here. And this Soling study, which I'll talk in more detail shortly, where they looked at different timings of these zeledronate, either at 6 months, 9 months, or watching bone turnover markers and watching them go up, or then trying to shut it down with zeledronate. It's also been, this is a reanalysis of the Fremantle study and showed basically fairly good results at alendronate. I'm quite keen on alendronate for the basic reason that this small dose going into the system every week catches the bone as it's waking up post-denosumab, whereas these big slugs of zeledronate, which will last in your system for a day or so and will only get onto the active bone at that moment, may not work quite as well. Okay, so raloxifene has also been tried here as well. This goes back to that question from the audience about switching to raloxifene after you can see there was a drop of 2.7%. So that there are drops with almost all of them. It's a bit disappointing, really, but that's why I would err on the side of continuing denosumab in the first instance, unless you really have to stop it, or their bone mineral density, their T-scores are now around minus 1.5. Okay, so just a bit about this Soling study published in JBMR last year. Okay, so this is a graph, this top left one, of percent change in lumbar spine bone mineral density, 0, and anything going down here is negative, so losing lumbar spine. And so this is patients who had denosumab, and then they were given, in the red line, they were given a Zol here. And you can see still, even though they were given a Zol, there were ongoing losses in the bone. And if they were given, but it's better than if they were given nothing. So nothing was this blue line. Okay, given nothing is what happens if you do nothing. If you don't give anything. If you're given 9 months Zol, so that's basically 3 months after you would have given them their denosumab. It obviously done nothing, so it matches the observation group to start with, and then it just tails off. But you can see, you know, these are all negative, all sites. It's basically not doing the job. And then if I just take your attention, look at this right-hand side graph, you can see the change in bone mineral density from baseline to month 12 for the lumbar spine, total hip, and femoral neck. And you can see they're all low. They're all dropped by 2 to 4%. No matter if you do nothing or if you do something. Okay. So the message here is that you will lose bone no matter if you give zoledronate at 6 months, no matter if you give it at 9 months, or if you do it based on rising bone turnover markers. And here you can see a bit of data for the bone turnover markers. You can see if you do nothing, that's this blue group. It goes up here. Once it goes up here, this is where they gave them as a zoledronate dose to bring it down here once it's gone out of range. But you can see with the 6 month and 9 month groups, you're still keeping the bone turnover markers fairly much within this grey region, which is the postmenopausal range. But as I showed on the previous slides, you're still losing bone. So these small rises are enough to cause ongoing bone loss. Okay, so overall, the message is the rebound in bone turnover markers seen post-cessation of denosumab can be suppressed by zoledronate, and then it tends to start to rise, but often within the postmenopausal range. The bone is still lost though. Other findings, so who loses the bone the fastest? It's often those who've been on denosumab for longer, and those who've had very high bone turnover marker baseline, and the younger patients. And there's studies ongoing in this area. Okay, so the message to you today is basically try not to stop denosumab, but if you do need to stop it, use a bisphosphonate. You can use alendronate or zoledronate. Exactly how to do it is the matter of some debate, and I'll just briefly go through these new European guidelines on denosumab that have recently been published. Okay, so essentially, if you're a young patient with a low risk of fracture, it's generally not recommended to be on denosumab. Okay, because we don't know how we're going to stop it. You need to have an exit strategy. Okay, if you've been on it for a short amount of time, so up to 2.5 years, you may be okay to switch to oral bisphosphonates or administer zoledronate, as per the options I went through just now. And then if you've been on for a long time, so you're more at risk of losing the benefits and these multiple vertebral fractures, then tend to continue denosumab at least throughout 10 years, okay? And in some patients, you may at some point want to switch to zoledronate. And the basic protocol, assuming you haven't got bone turnover markers, is to give a dose at 6 months and 12 months. So normally zoledronate is given every year, but here you're going to give, so denosumab will be 6 months, 6 months, 6 months, and zoledronate 6 months later, and then another one 6 months after that. And that will catch all the bone as it's waking up as much as possible. The other alternative is just start them on alendronate from the 6 month onwards. Okay, so those are the current ways to stop denosumab. And my point here is basically have a good think before you start a patient on denosumab. I've been referred a lot of patients who in the private sector have been started on denosumab with no thought to the exit strategy, which causes a lot of problems thereafter. Okay, so think, might they miss their injections? Because remember, you need to have your injection every 6 to 7 months. Any longer than that, and you're starting to lose bone rapidly and enter this enhanced vertebral fracture risk period, okay? So if they're very frail, you think they may not be able to make it to their hospital or to their GP for the 6 monthly injections, think twice, okay? Think twice what their prognosis is in general for their life expectancy. Think also, are they going to be able to get up to the hospital without any delays, for example, during the COVID pandemic? If so, if you're worried about it, have a think. Should maybe a bisphosphonate may be better, maybe raloxifene may be better. But often, you don't want to do more harm than good. So really have a good think before you start denosumab. It's a great drug. You'll see excellent. You'll see up to 20% increases in lumbar spine density, at the 10-year point. It reduces your fracture risk dramatically. So I think it is a great drug, but you need to think before you start it and think about before you stop it, essentially. Okay, so that concludes part 10, and thank you very much for listening.
Thank you, Alex. That was great. I can see Chana's already put a question up. Do you want? There's a few questions in the chat that you can see. Do you want to just type answer them? There's one about what you do in a patient with osteonephrosis of the jaw that was caused, we believe, by the bisphosphonate. And now he's better. Can he start denosumab, or is the risk just as bad?
Well, the risk is still going to be there. Maybe it might be a bit higher with denosumab because you've got that higher amount of bone suppression. However, the benefit is that denosumab is short-lasting, so you could try it and see if they can tolerate it. Personally, in these sort of situations, I may try something like Resegenet, which is a shorter acting bisphosphonate, and see if they start to tolerate that. Or if you can, try and get an anabolic instead, like teriparatide, depending if they meet the NICE criteria.
Sure. Okay, do you want to answer questions? There's a question about hypercalcemia, but I think Chana wants to share his slides. Chana, do you want to share? You've got a case.
Yeah, I'll try and answer as many as possible. I'll need to go, I'm on call.
Okay, yes.
Go back down. But
okay, we can't hear you, Chana.
Here. Okay, so is it onto my case now?
Yes, please.
Okay, fine. So thank you everyone again for still being on the call. So I've got a presentation which just wanted some acknowledgements. So Maya Al-Memar, who's consultant gynecologist, and Ambreen and Sanas, who are two of our brilliant registrars who helped to work up this case. So I'm going to present an interesting case, some learning points from it. Be grateful for your thoughts. It's a hot case, so we don't really know the outcome as such, but we have an inkling. But it'd be great to see what you think as well. Okay, so we have a lady who is of German origin. She's been in the country for a few years. She's got a long-term partner. She works as a nurse in West London in a nursing home. And she's not trying to conceive at all. And she's been on the pill for several years. I think when she was in her teens, she was advised to go on the pill, and she's been on Yasmin. And although a diagnosis of polycystic ovarian syndrome wasn't made, it was told that it would be good for her to be on the pill and it might help to regulate her periods, etc. Now, since stopping the pill 10 months ago, she's had no periods at all. I think she stopped the pill because she's beginning to think in a couple of years about starting to try to have kids, but she's not actively trying to conceive now. And she's on no medications. And so I was asked about her because she presented to another hospital with pelvic pain and bloating. She'd seen the surgeons, it was deemed to be a non-surgical abdomen, and she was reviewed by gynecology. Pregnancy test was negative, but they scanned her in A&E, and you know, there was no fetus that they could see, but they could see really edematous, enlarged ovaries. Okay. They did some blood tests on her, which is the point at which the case was discussed with me. And so really interesting blood test. So, you know, she's got an serum estradiol of 6,900, an FSH of 10.8, an LH of 2.4. Thyroid function is given. So the T4, our reference range is 9 to 26. The TSH is normal, between 0.4 and 4 is normal. And the prolactin is elevated, and an HCG was negative. So could you please on it should be polled on Mentimeter, but let's just confirm that.
Yeah, it is. I can see the question on my phone.
Great. Okay, so what is the cause of her clinical syndrome? What do you think is going on here? So it's not straightforward, but what do you think it's most likely to end up being? So do you think it's ectopic pregnancy? So, do you think it's something called ovarian hyperstimulation syndrome? Do you think that this is an unusual presentation of PCOS and actually she's taking some estrogen supplementation and that's why she's got such high levels, and this could be a variant of PCOS? Could actually be pregnancy, and because the ovaries are like this, we can't actually get through, and actually there's a fetus in there as well. So what do you think is going on? Let's see how many votes we got. Brilliant, we've got 40 of you voting. If you're having a guess, you're not alone. So please do have a guess. It's a good exercise. There's only 2 more questions after this, just so that you can plumb. So all of this happened. This has all happened within the last 3 weeks. So it's a really nice hot case, and it's nice for you to kind of join us in working through it. Okay, 5 more seconds for any more. Any more for any more? Right, let's stop there. Great. So this is actually ovarian hyperstimulation syndrome. So I agree with 46 of you. PCOS should never really cause this. We'll come on to risk factors for ovarian hyperstimulation in a moment. And regardless of, I mean, she had a negative HCG test, and I think the gynecologist can normally get pretty good views of the uterus through a transvaginal scan, which is what they had. So that really shouldn't preclude it. Maybe different with a transabdominal scan, but with a transvaginal scan, you should be able to see the womb quite well. And again, ectopic pregnancy wouldn't typically cause this. So this is what we call OHSS. Now, if you're wondering what on earth OHSS is, you're not alone, so don't worry. So this is an uncommon but not rare complication, which is often seen during IVF treatment. And most often it's really benign and innocuous, and it can be basically a bit of bloating, a bit of nausea, a bit of tummy upset, but that's it. And what happens is during OHSS is that high levels of FSH, so activation of the ovaries, leads to increased permeability of the blood vessels, and I think VEGF and other vascular factors are involved. And what happens is that you get transudation, so you get buildup of fluid around the abdomen, and in severe cases you can get pericardial effusion, pleural effusion, tense ascites, circulatory collapse, thrombosis because of dehydration, and it can be a really, really serious thing. That is rare. But mild is much more moderate. Mild and moderate is much more common. So she has probably a mild to moderate version of this. Right. So my next question is, following on from that, is what increases the risk of OHSS in anyone? So which of these are risk factors? More than one is true. So do you think this is PCOS that can cause it? Do you think fertility treatment after IVF or clomiphene, an activating mutation in the FSH receptor? Don't come across that every day. An FSH secreting tumor, again, not common at all. Or having an age above 40. Which of these do you think are risk factors? And again, if you don't know, have a guess. So in this woman, she's 38, she's been on the pill for a while, she's come off the pill, and she's amenorrheic, and out of the blue, she came to A&E with what looks like ovarian hyperstimulation. What risk factors might there be for it? Let's have 5 more seconds for any final votes. And this is a common condition which gynecologists deal with, but it's useful for us to just know a little bit about it, because we may occasionally be phoned about it. We'll cover it on medical take sometimes. Okay, so let's unhide the results. Yeah, so fertility treatment is the classical presentation. So it classically happens in a state where you've got something causing the ovaries to kick off and have high Ishtar levels anyway. And of course, you've got sort of super ovulation. So you've got FSH injections, and you've got HCG, which are really overdriving the ovaries, and that's the ideal conditions for seeing this. It tends to very much happen in women who have PCOS, okay, who have a high, on average, AMH, and therefore will have a greater response to treatment. So it happens at the time women's ovaries are most active during fertility treatment in the women who respond the most to this treatment, PCOS. And it classically happens with younger women, so those below the age of 40. And these two, even though rare, are actually, so these are all answers which are consistent with the diagnosis. So there have been a few cases, very few cases, of activating genetic mutations of the FSH receptor. Bit unusual why it should happen out of the blue in someone who is in her late 30s, and an FSH secreting tumor again, because it's giving the same conditions as IVF. And this woman, as we said, had been on the pill, had a history of acne, so maybe she had PCOS, but she hasn't had IVF in a history. Okay, so again, these are the risk factors, which is what I talked about. Okay, now the gynecologists, thinking of safety, and they were a bit worried about these really, really high levels of estradiol. So what they did is that they started microgynon, which is a combined oral contraceptive pill. And the rationale being they wanted to try to suppress the LH and FSH and estradiol to see whether they could calm things down in these ovaries and give some symptomatic relief. And a week after this was started, the pill, the estradiol came down beautifully from 6,000 to 623. The FSH came down from 10 to 6, and the LH from 2 to 1. And then I rang her up, and she basically said that despite the bloods getting better, she feels worse. And in fact, for the first time, she started developing she was sleeping in a chair rather than in bed. And she's of very good fitness normally, and she was starting to have difficulty walking beyond 5 minutes, which was very unusual to her. So we stopped the pill, and we wonder whether the pill, which contains ethinyl estradiol, which is not picked up on the estradiol assay, may have simply been replacing her endogenous estradiol with another form of estrogen which we can't detect on our assay. So in fact, the numbers may have got better, but in fact, her overall estrogen burden was no different. But that's a speculation. We were worried enough to, and remember, we weren't able to bring her in quickly enough because the gynecology non-urgent clinics are currently closed and they're just opening up. So we'd arranged a CT which showed no serous fluid accommodation in the peritoneum, pleura, or pericardium. So we were glad that it didn't look like we had any evidence after stopping the pill of severe OHSS. Okay, so going back to this woman, what would you like to do next in terms of investigations? So getting back to this woman with this unusual spontaneous form of OHSS, do you want to do an anti-Müllerian hormone? Do you want to do an MRI of the pituitary with contrast? Genetic sequencing of the FSH receptor? A thorough history about recent fertility treatment. So again, more than one can be picked. What would you like to do? What would be reasonable answers, things to do next? So there's a 38-year-old woman who has unusually come with apparent spontaneous ovarian hyperstimulation. These are her blood tests, just for recapping. Good. Let's give it 10 more seconds if we can. Again, if you just want to be reminded about the blood tests, they're up on the screen right now. All right. Right, okay, so again, really tricky case, and a reasonable number of people have put stuff down for everything. I think I agree that the most important thing we have to do is rule out whether or not she has, unbeknown to us, taken clomiphene, had some IVF, something to stimulate her ovaries. Has she got a stash of clomiphene around? In other countries, it's much more readily obtainable. And she has been asked several times and quite blankly says, absolutely not. I have no interest in getting pregnant. I don't want to get pregnant right now. I have not taken that. So we feel quite convinced about it, but you can actually do hair, urine, or serum tests for selective estrogen receptor modulators. You can do tox screens if you want to. An MRI pituitary with contrast, yes. So let's just go back to the history. So do you notice that the TSH is normal, but the T4 seems unusually low? And of course, the other thing that's odd is that the estradiol isn't suppressed. Within an estradiol, her LH and FSH would normally be expected to be undetectable, wouldn't they? However, they're not. And even when she was given the pill, they were still detectable. So now, if everything was normal, then sure, we could think about genetic sequence in the FSH receptor. But that probably wouldn't be a what should we do next? And I don't know about you, but this would be not a straightforward test to organize or a cheap one. And I don't think an AMH would be informative to the diagnosis. We know she has ovarian hyperstimulation. She has a pretty good history suggestive of PCOS. And in this state, I'm not sure how informative. I'm not sure what the AMH would come back in any case. So I'd recommend an MRI of the pituitary with contrast to investigate pituitary function further, and a thorough history which showed that she definitely had not had any form of drug stimulating her ovaries. So MRI was done last Tuesday, and this is what we had. So if you can see here, there is a very large adenoma measuring 41 by 41 by 24 millimeters. That looks to be optic chiasm and optic nerve involvement on one side. So she's undergoing visual fields urgently this week. She's been discussed in a pituitary multidisciplinary meeting and will be for surgery, although it may not be curative on its own. So she'll probably need some other form of therapy, including radiotherapy, and is likely to need pituitary hormone replacement, so is undergoing further testing. And the prolactin could be secondary to a high estradiol, or it could be disconnection hyperprolactinemia as an alternative. We currently don't have her on anything to reduce symptoms because she's not that symptomatic. Two options could be to give her daily progestogen, which would be a way of suppressing LH and FSH and GnRH to try to lower the burden of estrogen, since the pill seemed to do that, but unfortunately replaced one estrogen with another. So progesterone is an alternative. The only thing about that is we're slightly worried about sort of thrombosis risk, particularly in someone who could be a bit dehydrated if the OHSS worsens. And another alternative is giving a GnRH antagonist to see, not an agonist, which would risk a flare-up, but an antagonist. But we haven't done that as yet. So in summary, it's a really interesting case of someone who's got spontaneous OHSS, background of probable PCOS, probably has an FSHoma, and has secondary hyperpituitarism. She's awaiting surgery, and obviously we keenly await the results of histology and reduction of estradiol levels to confirm the diagnosis. Thank you.
Great. What a great case. Thank you very much. Now I'm going to just quickly share the QR code for today for everybody. If you want to, please give us some feedback. So take a picture of that with your QR code reader as you've done before if you've done any of these sessions, and then feedback on all. Have got time. I'm looking for more people to take on the study that's comparing prednisolone with hydrocortisone. We're also doing an international version, which is looking at different forms of prednisolone, but all the details are on there. And I can, if you're interested, if you put your email address into the second answer, that will work. I'm making the right diagnosis. I'm just going to tell you about a case, a real case, 26-year-old patient who was hypertensive, and the GP basically referred the patient to a hypertension clinic about 4 years ago. and the patient was seen in the general medical clinic, which is what that hospital had. And the registrar in the clinic wrote, needs a secondary causes screen because she's only 26 and the blood pressure remains quite high. So I want you to, using Menti, if you'd like to type in as many causes, you can type in one by one. So whatever you think of, if you type it in, and when you hit submit, it should let you put another answer in. So I'll give you a few seconds to think about some secondary causes. Put some key things. So first of all, history and examination are really important, okay, for some of these things. Now, Conn syndrome has no clinical signs, and so the only clue really would be hypokalemia. Okay, this is going to work, I think. Good, okay. Then, of course, history is important if you think the patient might have a pheochromocytoma, because that is one which has got a particular set of, in the history really, has got a number of features. Basically, these are the causes that you've all put, and thank you for doing that. Okay, so Conn's, Pheo, Cushing's, 3 adrenal things. So for Conn's, no history really, but hypokalemia. Pheo, history is quite important, but you get false positives of the history in some anxious people. Cushing's, please make sure there are some features of it, at least a bit of clinical examination to go for it. And then, of course, there's renal artery stenosis, where they have secondary hyperaldosteronism. So we've talked about Conn's in detail, and I won't spend any more time on Conn's, but I have made a copy of the 30-minute session we did. So this is very exam-oriented, but it's all about how to diagnose Conn's, how to do the suppression test, and how to interpret the venous sampling. So if you want to watch that at double speed, now you can, because I made a YouTube copy of last year's 30 minutes on that. And if you need to, I think it's worth thinking about that. So this patient in the clinic had a blood pressure of 150/90, so a bit high for a 26-year-old, potassium 4.1. So I think that makes Conn's quite unlikely really, because the potassium's so good. The BMI of the patient was 23.9. I think we should do an overnight DEX suppression test in this patient who has a BMI of 23.9, that's the same as my BMI, can run upstairs and has no clinical features Cushing's except that they're hypertensive. So you can, yeah. So I think no, not needed is correct, okay? And some people say, well, this is do it anyway. And so if we do it anyway, this is what happens, okay? The post-overnight DEX suppression test cortisol was 64, okay? So to recap, the patient is hypertensive, not hypokalemic, has no clinical features of Cushing's. The overnight DEX suppression test was 64. Now what do we do? Okay, because it's more than 50. So you can do an MRI pituitary, you can do an IPSS, you can do both, or you can do neither. And I'll give you 10 seconds to. So to recap, it's a 26-year-old patient who is hypertensive, normokalemic, can run upstairs, and I want to tell me which of those tests you'll do. MRI pituitary, IPSS, both, or neither. Okay, I'm delighted that we'll go for neither, which means we shouldn't have done the DEX suppression test, really, should we? 10 of you want to do an MRI pituitary. Now, if the patient does not have Cushing's, this is what would happen, okay? If you do an MRI, 22% of us have a 3mm pituitary adenoma. So that's a non-functioning nothing, and it will mislead you into thinking that the patient has got a pituitary source of their normality, of their slightly raised cortisol. So to me, that might be a false positive, but we shouldn't have done it. Okay, we shouldn't have done the DEX suppression test. That was a mistake. If you do an IPSS, as I said last year, you will definitely say the pituitary is the source, because that's where your ACTH comes from in normal life. So my key message there is don't do an LDDST or an overnight DEX suppression test unless you think I need to exclude Cushing's. Okay, and if you voted for the MRI pituitary, then you need to watch this. This is the other thing I put on YouTube. So this was from May the 18th. If you scroll down through our last year, the bottom one there is what we started with, calcium. There's the venous sampling. So that's Conn's on the 4th of May. And that's a YouTube video on all of the features you need to know about Cushing syndrome and wrong diagnoses. And I put YouTube ones there, as I said, to make it easy for you to find. Okay, so as you rightly know, these are Pheos, Cushing's and Conn's are the causes to think about. Think about renal causes and then try and exclude them. So this patient had these things sent off, and all of them were negative, apart from that borderline positive overnight expression test, but then had a 1-month review, okay? And this is where the story then unfolds. So she's hypertensive and 26 years old, and she didn't attend the 1-month follow-up clinic. And nobody looked at the results, but filed neatly into the notes by somebody was a raised set of metanephrines. And they put in the patient's notes, paper notes, 4 years ago, and that was that. Time goes by. She has episodic severe hypertension, okay? She has a high set of metanephrines in her notes. After this is all uncovered, she gave us a history, and she particularly noticed that after sexual intercourse that she would develop tachycardia, pallor, and sweating. And her partner thought that it was his performance that was enabling all this, whereas of course it's not funny, because 4 years later she became pregnant. She wanted a termination, so she went to see her GP about this, and one of the problems is that termination is a very common event. And so there are lists of terminations done by very junior staff. So the patient was admitted as a day case, nearby my hospital, come to the hospital for your terminated pregnancy. Nobody knew that she had a hidden pheo 4 years ago that was been growing, so it must be quite large by now. So she comes into hospital a bit dehydrated, like anybody is nearby mouth, for the procedure. And the anaesthetist is an SHO, because they just do a list of 10 per terminations. It's not deemed a really difficult or dangerous anesthetic, because they're all very young people. So this poor SHO gave inductive anesthesia, and the blood pressure went up to 240/170. And then he opens the notes and finds this piece of paper that says catecholamines, and realizes the whole penny drops, thinks, my goodness, it's a pheo. What shall I do? So he bleeps you. What shall I do? I'm in theatre. I've got this patient who's very hypertensive, and the notes say very, very high metanephrines. So we're definitely got a diagnosis. And you do a quick search of the internet, you find there's a number of drugs available, but I'm going to tell you that phenoxybenzamine is a slow, non-competitive blocker, and phentolamine is a competitive antagonist with rapid onset of action. So of course the patient is worried about her malignant hypertension, and guess what they have on the trolley in theatre? They always have phentolamine, which is for hypertension in general. So you're called and you need to make a call. Let me just advance this to let you make a call. So you've got two options. Will you advise the SHO to give that vial of phentolamine? This is what the BNF says. It says phenoxybenzamine used for elective preparation for pheos, known surgery, and phentolamine used for emergency hypertension control in pheos. So I hope you're all voting. So there are your two choices. Give the phentolamine or don't give the phentolamine. I'll put dose question mark there. So let's see what so 42 of you are going to do what the SHO did, but it was a bit tragic because the problem is, right, this patient is dehydrated, okay? So if you take someone who's dry with very, very high noradrenaline levels and completely block them with a 5 milligram bolus of phentolamine, you will reverse that immediately and have a tragedy, really, because this is what happened. The patient had a hypotension-induced subendocardial infarct and a stroke caused by the phentolamine. She survived but disabled. Okay, so this is tragic and going through the courts now. So what should we do? Okay, so the first thing, before you give an alpha blocker, you need to rehydrate patients. Now, I'm sure you'll do that electively, and it was a panic and things go wrong. But if the patient had some saline running, and it's many things came together. Okay, it was firstly, the patient didn't have a drip running because they just do a list of 10 termination of pregnancy in a morning. That's what happens. It still happens today. And so what you need to do is give some saline. Okay, if you give saline and start to fill them, then that phentolamine would have been fine, because then the blood pressure won't crash because you haven't got a volume problem as well. So basically what you want to do is give some fluid and then give a little bit of phentolamine and then see what happens. Now, I won't go through all the details of what pheos are, because of course you know that. And I will leave that up there. In fact, I'll leave the slide up to the end and let you take a picture of that QR code. So this slide is one of my favorite old slides from Netta. And I'll just point out one really quite interesting thing that he noticed, okay? And that is when you have a primary pheo on the left, that is a pheo where there is a single tumor, it's quite big, normally 3 or 4 centimeters, the patient has episodic severe hypertension, okay? And this is the dangerous thing that causes strokes and heart attacks and death. If the patient, on the other hand, has multiple metastases from an adrenal pheo, okay, lots of tumor, then the patient's blood pressure does not vary at all. And that's because all of these different tumors secrete, they're all metastases, they all make the noradrenaline continuously, and you don't get the syncytial effect of having one tumor that degranulates. Good, thank you all very much for joining. I'm sorry I've overrun a bit. I will leave that slide there with a question about whether you want to take part in some research. In the future, there is, first of all, there's a lot of stuff. So last year when we did this, there was nothing else on. I think we were the only thing, because it was April, it was at 1 month after lockdown. And so we did it every couple of weeks. But now we've covered most of the curriculum, and also there's plenty of other choices. So there's lots on. The RSM has got some sessions on the 4th, 5th, and 6th of May. We will probably be doing a pump course in May sometime, and then the next time will be after that will be the Pituitary MDT. There's a lot of stuff on this site which hasn't really changed. The management of Conns and Cushings and pheos and calcium, all of those are very up to date. I'm going to try and make YouTube versions. If you want to watch at double speed, then you can. Okay, good. Thank you all very much, and see you next time.